Yes, it's been fascinating listening to you all this morning, and thank you for all those presentations. I have worked with renal colleagues before, particularly on communication skills, but it was really interesting for me to hear about the difficulties and the problems that you experience. I'm also having a lovely time at the moment. I live part of the year now. I'm based in Spain, where I'm working with people in Gibraltar who are setting up a hospice there, and where I actually run some nurse-led clinics there as well, which is really nice. So I was quite impressed this morning when Karen mentioned the fact that, well, are we making progress? Well, if you look at that slide there, that is the professor of medicine in 1983 who wrote that effective communication is perhaps the most important attribute to successful medicine and nursing. And how we talk to patients is often we give them strife or we give them serenity. And that's quite a large responsibility, isn't it? And that is something that we do every day with patients. We talk with them. And so you can say, well, 30 years later, she's still standing here saying the same thing. Well, we have made progress. Yes, we have. We've got better at understanding the things. However, last year in the UK, as you can probably imagine, was really an awful year. We had a problem with the media. The media, well, it's still going crazy with us, but not quite so much this year. We had the Nürburgring report. We had the Care Commission. We had the Francis report. We had the national audit. Well, that's this year as well, the national audit. And what were they all saying? They were all saying that we got a problem with communication. Yeah? So you can imagine actually that really last year for us was pretty demoralising. You know, you went to work and you felt, well, why are we bothering? Because everyone was saying how awful we were. We're not as bad as that. However, it is still continuing because the national audit that was actually published last week, the end of last week, does say that there are large variations. There are some places that are giving fantastic care and others that need some help. There were particular issues, though, with communication. And I found it was quite interesting that healthcare professionals had recognised patients were in the last days of life, but had only told less of them, less of half of those who were capable of discussing it. Now, I'd have a slight issue with that because I want to set out from the start. Not all patients want to discuss it, right? And that's the skill that we have to have. Have we got the skills to actually determine who wants to discuss what? Our health ombudsman in the UK, and I'm not going to focus just on the UK, but this is what our health ombudsman says to us, that we're careless, we're insincere, we give unclear explanations, and then we have a surgeon who accused someone of being a baby because he expressed anxiety about having an anaesthetic, right? And it says that we need to get better at listening and responding to concerns. There are times, well, certainly since I started preparing this for today, there are times actually when I'm beginning to think I wish I lived here, because your health ombudsman, right, and he's new, I gather, this health ombudsman, he has said that there is a very low volume of health services complaints to the ombudsman, and it's a matter of concern for him. Well, where do I want to be living then? Here. However, I thought, well, surely there must be something wrong here. And he does actually say that we find that poor communication often underlies dissatisfaction. Your survey of education, your educational survey, also says one of the key points that effective communication is key and all staff need relevant training. And I was fascinated when I looked at your top 10 priorities. If you look quickly down there, there isn't one of those that doesn't actually involve good communication, right? Advanced care planning, that's been mentioned many times this morning, which is quite interesting. Patient assessment and management, and communication at issues at the end of life. And some of these issues I'm going to look at today. So what are the principles of good communication? Well, we have to have tools, right? We also have to have some structures, okay? So we have the structure, where I am, what do I want to achieve when I'm having a conversation with a patient or discussing things. What skills do I need to get there? And what phrasings and behaviours can I incorporate so that it's very personalised? It's me who's talking to the person. I don't want you to say that, to for example, to look at a video and then just say, well, I've got to say it like that. It's very much how it's a personalised thing of how you feel comfortable in saying things. But before we do any of that, there's a thing called self-awareness. Philip Bernard wrote this many, many years ago and said that unless we have a good look at ourselves, right, we can't change unless we notice what we do wrong either. So, I wonder how many of you, I'd love to know how many of you ever listened or tape recorded or video recorded a conversation with a patient. Can you put your hands up? How many of you have done that? Oh dear, right. Shall I tell you how I'm going to tell you how I learnt really my communication skills then. I was fortunate enough to work for many years with Peter Maguire, Professor Peter Maguire. Some of you will know him, some of you won't. He died very sadly about 5 years ago, maybe more. And he set me off with a tape recorder to record my assessments of patients with breast cancer. I then had to listen to my assessments, right? So I had to listen to myself over 500 times on tape recordings. And my goodness me, do you learn a lot from listening to yourselves. I've often said you don't need any courses really, just go out with a tape recorder and listen to yourself, because you really do learn a tremendous amount about yourself and about your skills. You know, when you watch television you say, oh God, isn't that awful, isn't this awful, how you can always pull people to pieces. And then when you see it yourself you think, well, I've had to do something differently then. So it's an amazing way of learning. So I want to ask you, because following on from having listened to myself, I thought, I was working with the nurses on the wards, I thought there are very different styles of communicators out here. I wonder, I'm going to have a look at all of them, and I'm going to analyse all their conversations and have a look to see how they're communicating. So there were three styles of communicators really. There were those, the ones who inquired. There were those, the ones who were really keen on giving their information. And there were those, the ones who really weren't listening very much. They were just ignoring what the patient was saying, right? So, and the interesting thing is that for two of them, they were actually not aware until I played their tape recording back to them, with them. They were not aware of what they were doing. So that's why I beg you to all get yourself on a video or get yourself on a tape recorder with a patient. What do the inquirers use? What kind of skills do they use? Right, they're the ones that listen. Another fascinating thing that I found when I was doing the original research was, because I was a research nurse, I had to assess patients, their psychological status, their physical status, their social status. I had to assess the patient as a whole. What I couldn't do was answer their questions, right? Because I would have biased the research. That was very hard for me not to be able to give my pennyworth, right? But you know, what did I learn from that? The fact I had listened and used some of these other skills. I'd never answered questions. The patients used to say to me, I can't tell you how helpful you've been today. It really has been so good. I hadn't done anything, because all I had done was assess, and it was an amazing lesson to me, because I clearly before must have rabbited on like something crazy and no one ever heard me. So it's really important to listen, to have pauses, to have silences. Again, you need to look at yourself on the videos or tape recorders and see whether you're having these. To pick up cues, and I'm going to come back to picking up cues in a minute. If the patient's saying, I'm feeling really tired, right? That's very important to pick that up, particularly where you're working, because that tiredness could be psychological, but it also could, as I've learnt this morning, I'm quite proud, I've learnt this morning, it could also be physical as well, yeah? So you need to pick up these cues. You need to acknowledge, so you've been feeling tired, right? That's all you need to do. You need to encourage them as well, to say, can you tell me a little bit more about that? You need to use open questions. How are you? How do you feel about what I've just told you? Right? Not the closed questions that just have the yes and no answers. When you get really stuck and you think, oh God, what do I say now? What on earth do I say? If the patient says, for example, I've been feeling really, really tired, you can get out of that, or let's take a more sensitive issue. I'll pick up from one of Max's. Max was talking about sensitive issues about sex or something like that, and the patient's saying, I'm having a really difficult relationship with my husband, right? And you think, oh, what do I say now? If you reflect that back, right? So you've been having a very difficult relationship with your husband. That is giving the signal to that person that you want to talk about it or are prepared to talk about it. So you haven't asked a very, very direct question, you've just floated it back. Yeah? So, and clarify, you need to clarify, what exactly do you mean by you're having a difficult relationship if they want to talk about it? You can use educated. What I sense I'm hearing from you is that it's been a difficult time between you and your husband, yeah? So you're having an educated guess. If that's wrong, they'll say to you, oh, no, I didn't mean that. They will tell you whether you're right or wrong, believe me. Also, you inform, however, you inform in a particular way. I'll come back to information in a minute, because basically I think it was probably around about the beginning of the 90s when we had this crazy that everyone has got to have this information, and we've honestly, and most patients have information overload, and I'll show you what I mean by it in a minute. So what you need to do with information is to give them a tiny, what we call chunking and checking, giving a tiny little bit of information and then checking out that they've understood what you said. And summarising. You can't do enough summarising to check, and this summarising also gives you an amazing amount of control, because what you often say is, we haven't got enough time. So if the patient is saying to you, well, I've been feeling very anxious, I've been feeling very tired, and actually I've been feeling down, you summarise back to them what they've been feeling. Is that right? Have I got this right? So all the time you're keeping your conversation with the patient on the patient focused, okay? And the one skill that is probably one of the best, certainly in palliative care, is the empathy, right? It sounds from what you've been saying as if you've been having a really tough time. That's what empathy is. And you're hearing what that patient is saying, and you're telling them that you have heard what an impact this is having on them. So the evidence, well, I'm not just talking through my head totally anyway when I say that those are the skills that facilitate. A silence, they have been shown, or a small prompt is most likely to make the patient actually disclose their concerns, right? Giving information, a large amount of information, actually, if you go into that information mode, that the likelihood of further disclosure from the patient is reduced. And so the Americans say, I don't quite believe this, but anyway, if you say to a patient, is there something else you'd like to ask me about, rather than more, is something more is more likely to actually more likely to give more opportunity to the patient to ask questions. Now, a cue. It's either a verbal or a non-verbal hint which suggests an underlying unpleasant emotion. Psychological, I'm worried. Words which describe a physiological link to a psychological state, I'm not sleeping well. A throwaway comment, well, you cope, you know. Or the mention, just a cue, well, my dad died. Right? Those are all cues that the patient is giving you. You know, when you go to the doctors, and I've said this for so long, really, that when you go to the doctor and you give them an idea of how you're feeling, right? Now, you only really tell them what you want them to pick up, don't you? Yeah? And that's the same with patients, right? They're only saying it if they want you to pick it up, because often we're very frightened of doing more damage by going in and actually exploring what it is they're concerned about. If you respond to the first cue, you set up a very good relationship with the patient. What we found is that what will happen is that patients, when you are listening to a conversation with a patient or with a healthcare professional, if the cue is not picked up, the patient will probably give it to you another time. They could give it to you a third time, but if it's not picked up on the second or the third time, they then say, this person isn't the person to discuss this with, right? So it's really important when you hear it to respond to it. Open questions are far more likely, right? Far more likely to lead to disclosure. And open questions and cues are much more likely to lead to a patient-centered consultation, which is what we want. Now, interestingly, often people say, I haven't got time at all. There isn't the time. Well, if you respond to cues, it shortens the consultations, as was found with oncologists, right? They had shorter consultations. And doctors who responded to at least one emotional cue had shorter consultations. So and the reason is because you are centering it back on the patient. So if you're centering it back on the patient, your consultation time will be less. But cues are often missed, and so what people do is they change the subject. I'm feeling very tired. Yeah, I'm feeling tired and I'm feeling low. How's your appetite been? Right? No, it's true, honest. Don't believe me, it's honest. People go into inappropriate information. By that, they go into reams and reams of information, right? Which the patients can't take in. They use closed questions, that's the yes or no question, or I've been feeling really tired, and I haven't been sleeping very well, and my mouth's very dry. Now, if a patient is giving you all those cues, right? You go back and ask them multiple questions about them, right? As well. So only ask one question at a time. Requesting an explanation is, I haven't been sleeping very well. Why haven't you been sleeping very well? Now, can you see the difference here by saying, why aren't you sleeping very well? What's stopping you sleeping? Yeah? It's a very, very subtle difference. But the why question is as if it's quite intimidating. Well, for goodness sake, why aren't you sleeping, right? Whereas if you say, what's stopping you? So sometimes the why question can be perceived as a little intimidating. The normalising stereotypes. Well, you know, I'm really not looking forward to the dialysis. Oh, that's normal. We see a lot of that. Okay? That's a normalising. Now, what is the real crux here? The crux here is, what is it they're concerned about, the dialysis? Not, oh, it's normal, we see a lot of it, because it just brushes it under the carpet. And the patients don't feel then that they can talk about what their concerns are. Selective attention to cue. Yes. Well, what we always do with that is, rather than the physical, we will always go for the physical cue rather than the psychological cue, if there's two given together. You know, my pain's much better, but I've been feeling really low. I'm so glad your pain's a lot better, because that's our human nature. It's easiest for us. Passing the buck. Don't see as much of that these days. It's, well, you better ask the doctor. And the patient may say, do you think I'm dying? Well, you better ask the doctor, right? And I mean, I've got people recorded that. Honestly, you may laugh, but it's true. Changing the focus of to the relative. This is another opt-out as well. You'll say something like, I really feel that I've had enough of this. What does your husband think? Right? So you've changed the focus to the relative, yeah? It's not what the husband thinks at all. It's what the patient's saying and what the patient is feeling. But we do it because we're slightly thinking, oh, I don't know what to say, so we change the focus to the relative. Oh, I've been really nervous about the dialysis. No need to worry about it at all. You're in the very best place. Honest, you are in the very best place. Yeah? You're defending your patch. No, that's not what the issue is here. It's what they're worrying about. Yes? So it's making certain that you're picking up the cues and using what you've got using the information you've got from the patient. Oh, come on, it's not as bad as all that. You'll be all right, you'll be fine, you'll be out soon. The jollying along. And you'll find the premature reassurance. No, it's not that you're going to be absolutely fine. Yeah, it's a difficult situation and we hope that things will go very well. That's realistic, right? Very realistic, not just saying, oh, you'll be absolutely fine. Because you can be sure, well, I'll tell you with pain control, it's one of the typical ones, isn't it? Don't you worry, we will be able to control your pain. And I'm sure Max will agree with me that when we go around saying that, we will be able to control your pain. That is the one patient who we have real problems with, yeah? So it's much better to say, we have got a lot of medications, a lot of things we can do, and hopefully we will be able to control your pain. You're not saying you can, you're not giving that false information or false premature reassurance, you're just saying, yes, we're going to do our very best. So there's just been a paper published recently from the group in Leicester, which they've done some lovely work actually. And this is what their findings are, that the evidence suggests that still we're unable to demonstrate empathy. We are bad at acknowledging the difficult time. We still use throwaway comments that trivialised what the patients were saying, and we often appeared blasé and failed to offer hope. What the patients were saying, please, we want to be treated as individuals and respected as fellow human beings. We want to be listened to. Not have what they've said dismissed. Be warm, friendly, compassionate, honest, and we'll do our very best. That's what we're here to do, our very, very best. And so you see, that's 2013. So what I was describing in 91, we are still having some difficulties. This is what one of the patients said about information. You just need little bits. Patients' minds get, well, as mine does, to be honest. If people give me too much information, I mean, I get totally sort of confused as well. So if I'm not feeling well, I can absolutely understand why that's happening. And so you see, some patients, these are other patients for the ignorers and the informers, and I love this one. Nurses should explain the things that really worry me, not be someone who recites a pre-prepared speech. Aren't we all guilty of that at some times? Yes, you're smiling at me, so I know I'm true, I know it's right. And then there's someone who says, well, I realised afterwards, then they told me nothing. So, when we're having conversation, we need ice. This was first described by a friend and colleague, Jonathan Silverman, way back in '98, but it's still a really, really good framework. When you're having conversation with patients, you need to find out what their ideas are, what their thoughts and feelings are about their condition, what their concerns are, and what they had hoped for as well. So you get their perspective on it. The most important thing is that you get the facts, but facts very often they come with feelings as well. So it's a matter of getting the facts and the feelings integrated. Yeah? So I hear you're going to have some dialysis. How are you feeling about that? I've got the facts. I now want the feelings, yeah? So what stopped us from really hearing what the patient's really saying? I'm going to ask you that. I want you to give me some ideas about what you think. Why do we always find it quite difficult to have honest and open communication? Anyone know? Sorry?
Our own feelings. Our own feelings.
Our own feelings. What are you frightened of?
I suppose sometimes if you over-connect with the patient.
Yes.
And it's actually too hard, too upsetting to go with.
Absolutely. It's an emotionally draining. You're absolutely right. Yes, absolutely. Anyone else? Any ideas?
Maybe not wanting to give bad news.
We don't want to. What may be stopping us from giving bad news?
I suppose sometimes you fear that you upset them too much,
Yeah.
and that they get upset, and
How will I cope with that? Absolutely.
It depends,
Absolutely.
It's afraid to open up and purpose, because
I totally agree with you. Absolutely. Well, these are the reasons. Well, one of the reasons I'll show in a minute. But actually, it's often not what you say. The impact is often determined, right, by your body language, your gestures, and your postures, and your tone of voice as well. Actually, only 7% is actually the content. So we're frightened of upsetting the patient. Just what you're saying. Again, unleashing the strong emotion. You could have been writing this while I was talking about it. Of causing more harm than good. Of being asked answerable and difficult questions. Why me? Of saying the wrong thing and getting into trouble. Or of the conversation taking up too much time. Hope I've addressed the too much time. The why me, we heard about that today. Some of our patients ask that. We've always been frightened that if we talk to patients about their diagnosis or prognosis, it will emotionally upset them. We did a study across 8 countries in Europe, partly because our Southern European partners were saying, oh, we can't talk to patients about diagnosis or prognosis at all. And the evidence, what the evidence shows is that there is good evidence that open disclosure, if you're open with patients, has a positive effect on psychological outcomes. Strong evidence and trends to suggest that they prefer it. Non-informed patients seem to appear to have more psychological distress. Informed patients had less psychological distress. But I think the most important thing for me is that if patients, and this constantly comes up, if patients have ambiguous or conflicting, right, So someone in the audience said today, I think, how important it was that we wrote down what is being said, right? Because I absolutely appreciate that very often one healthcare professional may say something and then it's slightly different to the next one, and that causes patients a lot of anxiety when they're getting conflicting ideas and conflicting reports. Can communication skills? I'm not going to stay very many seconds on this. I just want to tell you that yes, they can. You can either teach them over say half a day for over 6 weeks or something, or you can do them 2-day courses, or you can do 3-day courses, and the results actually seem fairly similar. The randomized controlled trials, we have Leslie Fallowfield did one, Razavi did one in Belgium, and I did one for the nurses as well. And there's good evidence to suggest that you can teach communication skills. How you teach them? We get people to reflect, right? We get them to imitate, right? And we get them to actually experience, and it's the experience bit that makes the difference. So what do they like best about this kind of teaching? They love the fact that it's relevant. The course is always set up by the participants themselves. They say what they've got, that what their problem is that they want to address, and that's what they work on. Nothing else but what they want to work on. So the course is always very participant-centred. The second thing that they love from up there is the actors, and you won't believe it, they actually like role play as well, which is very interesting. Actors have made an enormous difference to our training in communication skills. That's an actress I worked with, the very first actress. She actually came here with me, the very first time I ever worked with actors, and they are just so brilliant at helping us improve our communication skills. Look, we can learn from DVDs, we can look at books, right? Theoretically, very often we know what to say. The crux of the matter is, can we actually do it? Can we put words into action? Because I real honestly tell you that if I said to you now, could you tell me what, could you possibly tell me what you might say to a patient if they asked you a difficult question? You'd probably be able to tell me, right? Whether you'll be able to put it into action with that patient is another matter. And the only way you can find that out is to practice it with an actor. There's lots that you can do, a tremendous amount of communication skills training online, all the what I call the theoretical stuff, but you then need to have the chances to practice in simulation. It's really, really important. So, where are we now? Right. I've had some difficult decisions to make listening to you, because I want to show you one or two videos, clips. Now, someone said this morning that they'd never been asked how long they had to live, right? So that's a difficult question, so I'm possibly not going to go down that route. But I also realised that there were some people were finding a situation that was difficult was when you have to address the issue that the patient's nearing the end of their life. Yeah? So would it be helpful to have a look at a clip on that? Yeah? We hope. No, hang on, Max, we're not there yet. Not that one, we're not going to do that one. Well, wait a minute, before I put the video up, I'll just go through this one. If a patient asks you a question, whatever it is, am I dying? The most important thing is not to just go straight back and say, yes, you are. Right?
What's wrong with that?
Come on. There are many reasons why people sometimes need to know, right? And it's really important to find out what's made them ask you that question. Yeah? So, that's a difficult question you've just asked me. It'd be really helpful if you could just tell me what's made you ask me that question today, and to get them to give you the reasons. And to then actually If they say them, and then so you're saying that, you know, you're feeling tired, you've just had enough of this, you really can't see the point any longer, okay? If they carry on that and say that's what they tell you, then it's appropriate to say that actually you yourself seem to have worked it out, don't you, that you think you are dying. And I think you're probably right? So all you're doing is confirming their views and their thoughts. When the question about how long have I got comes up, again, the only thing I would say about that is it may be because it's always important to find out what it is, what's made them. Is it an anniversary? Is it because they want to do something? Have they got a bucket list of something, all these things that they want to do? And that's sometimes why they're asking that question. And I think you're absolutely right. You can never say, you can't give a time. But if you may be able to help them with the decision of saying, well, if they want to go off, I don't know, to the West Indies, you may say, well, actually, that's probably not realistic. Do you see what I'm saying here? That it may be because it's for a particular reason. And what you do there is you don't then go and say to them, but we can do this and we can do that and we will control your pain and we can do all the rest of it, all right? No. Just wait. See when you acknowledge how distressed they are and see what they bring up, or if there's anything that they would like to ask or something that they would like to ask, and only address those issues at that moment in time. Because if you go in and start saying to them, well, we can manage your pain and we can manage some other symptoms, they may not have those symptoms and you may incur more worry for them. Yeah? So it's only to address at that moment in time what they have. However, there is sometimes when people, and this is real life, when people ask the question, am I dying? And you say to them, what's making you ask me that today? And they'll suddenly think, oh, she's going to tell me. I don't want to know. And so what they've done is they've tiptoed and put their toes in the water and suddenly realise, actually, I don't want to know. Right? And they say things like, oh, do you know, it's just how I'm feeling today. It happened to me with a patient with lung cancer. And he just said, oh, you know, it's one of those bad days, Susie, I'll feel better tomorrow. He didn't want to talk about it at that moment in time. And that is fine, absolutely fine. You've given them that opportunity. So if they say no, leave it there. So if we have a look at the structure for handling a question like that. I think she did that, didn't she? She established what the patient knew. Where is the patient up to now? How much, you know, are you okay to go on talking? Yes. She then gave a warning shot, didn't she? She got all the facts out, she realised where the patient was up to, she knew that, and she gave a warning shot that the news wasn't good. And she, I think, broke the news in fairly simple terms. Sue's a great heart failure nurse, and I would have, and she knows, and I publicly say it, and she's quite happy about that, I'd have a little bit of an argument with her about what she said. She said, you're moving towards the end of your illness, right? Well, if that's cancer, we'd be saying, yippee, right? If you see what I'm saying. She didn't actually say you're moving towards the end of your life. And when she sort of saw it back, she realised that she hadn't said that. But the patient knew what she was saying, so that if the patient still knew what she was saying. But she broke it in fairly simple language that the tests showed, and everything was, you know, showing that what the patient has said in terms of deterioration, that she was deteriorating. She waited for a response, and she waited a long time, didn't she? Because she kept saying, oh Dan, her husband. He actually comes in later on to it. And then she said, which you could say, well, what a stupid question. She said, how do you feel about what I've just said to you, right? And, you know, it can be, and there are times when I may have said that to a patient, and they may have said, well, how the hell do you think I feel? You know? But it's still showing that you're giving them an opportunity. And often I say, you may think this is quite a stupid question, but I'd really like to know how you're feeling now that what we've just discussed, about what we've just discussed. So it's a matter of how you phrase it or how you put it, but it's really to find out how they are. Then focus on the patient's feelings and encourage the patient then to talk about her concern, because she was saying then, well, my concern is, what's this? The defibrillator hasn't gone off. Well, come on. So she was going to sort that one out and she was actually going to tell her that they were going to send the technicians in to cut it off or whatever they do. I never know quite what. Cut it off? No, whatever. Right. Yes. And then check the patient's understanding and invite questions, right? And she was going to move forward of how they were going to look after her after that. So it's really important to have quite a nice framework. So it goes back to, where am I? What do I want to achieve? What are the skills that I'm going to use? Right. I heard this time and time again from you. And I think this was an issue that the heart failure patients and when we had the cardiologists and the heart failure nurses in to do the training, I think this is something that they all found was a difficult situation. How do you deal with uncertainty? And all you can really do is acknowledge that this, I really appreciate it. This is really difficult for you, living with this kind of uncertainty. And the minute you say that, they connect with you. They connect really well with you. And it must be difficult, and invite them to talk about the major concerns they have with this uncertainty. And the very fact that you're allowing them to talk about it actually gives a bonding between you and that person. So it's just making certain that they appreciate that you can see how difficult it is for them and offer them ongoing support. There isn't a lot you can do because it's uncertain, but at least you've appreciated it. For collusion, as you can see, the most important thing is always to ask the relative if the patient has been asking any questions. And invariably they have, or been making any statements about how they're feeling, because invariably, if they have, then the patient knows what's going on, right? And the thing to do then is always to say to the patient, or to the relative, look, I am obviously going to see how he is today. If he doesn't ask me any questions, if he doesn't ask me if he's dying, I'm not going to tell him, right? It's only, the issue is whether the patient wants to know or not. If the patient wants to know, then they have every right. So that the key to that collusion is indeed what I've just said. Oh, wait a minute, we're going backwards. So I'm going to wrap up. Any of you want and think that you can put yourself forward to doing a bit of role playing and stuff and having a good time? There are courses available. There's run now all across Northern Ireland. I've been working with Northern Ireland for over the last 10 years, and Anne and Emma now are taking the programme forward. They're also at Milford as well. Jim Rattigan and Kathy McLaughlin was the person who originally got them there, so they are available there. The DVD, the one you've just seen now, it's a new DVD. We've just made it. Macmillan have it. I don't think they're charging anything, so if you feel you want to get a copy of that, do. It's available for you from Macmillan. And I just want to leave you with one or two little quotes. This is by Henry Nguyen, who says that, a friend who can be silent with us, right? I think it's a lovely, lovely quote that he's saying, that how important silence is, and that's the friend who cares, who can be with you. The great thing is to know when to speak and when to keep quiet, right? Isn't it funny that these were being saying, all these quotes are coming from 4 BC, right? I mean, incredible, here we are talking about it today. And Confucius said, think more, listen more, be cautious in your words and actions. The advantage of doing this way is that you will have fewer regrets. Remember, all things are difficult before they are easy. I'm not going to read you the poem, but what I do want to leave you with, you have a very difficult job, particularly in your speciality, with all the uncertainty. Patients go up, they go down, and it's really, really hard. You have to remember, lots of these problems you cannot solve. No one can solve them. You can only try your best. Bad news is bad news. Serious illness causes distress. My job is not to make people feel good, right? My job is to try to make them feel less bad. There's a real subtle difference. And that's what we're after, compassionate care. Thank you very much.